is Val Jones. I'm lead physio for Sheffield Shoulder and Elbow Unit, and today we're going to talk about anyone for tennis, or what's going on with tennis elbow, or as it's more commonly known as today, lateral elbow tendinopathy. So thank you for joining me for this session. As I said, I'm the lead physio at the Sheffield Shoulder and Elbow Unit, and I'm very fortunate to work in a unit which has an international surgical reputation, especially in the management of elbow disorders. I treat patients both post-trauma and electively, and I lecture internationally on the assessment and treatment of elbow disorders. I publish and also present on podcasts. I'm a research active member of the British Elbow and Shoulder Society. I'm the UK delegate and board member of the European Society for Shoulder and Elbow Rehabilitation, which is known as EUSA. I'm also associate editor for the Shoulder and Elbow Journal. So tennis elbow, Nerschel in 2015 has already told us that it doesn't threaten quantity of life, but is a major impediment to somebody's quality of life, which is very true if you've ever suffered with tennis elbow. So today's objectives are to review the mechanisms contributing to pain in tennis elbow and review the physical and radiological tests to confirm the diagnosis. So why are tendons such a problem to manage? Well, pain and pathology occur when the load placed on the tendon exceeds the tendon's capacity. And we know that tendons are very slow to respond, so it's really easy to overload a tendon. If you read the work of Jill Cook, Craig Purdom, they talk about no more than a 7 to 8% increase a week in load, or the tendons will start to moan. But we find that patients' expectations with the tendon are very different. They feel a tendon should be able to increase the load quite quickly, and they have no idea about healing scales. In terms of time scales, they often expect a tendon to get better over a period of 2 to 3 weeks rather than 2 to 3 months, if not longer. And we also need to remember that pain and pathology and imaging changes can be totally unrelated. You can have somebody with a really painful tendon doesn't look too bad on imaging, and it doesn't change even when their pain is getting worse, it still looks quite normal. Or the converse can be true. You have a patient who is absolutely pain-free, but their tendon looks absolutely awful on imaging, and they get better, but the imaging changes don't change at all. So pain and pathology and imaging changes are often not correlated at all, especially with tennis elbow. And that's why you should never use things such as ultrasound scans and MRI scans to help sort of say whether a patient's made an improvement or not. It should be related to pain and function rather than imaging changes. So what's the epidemiology of lateral elbow tendinopathy, which is what tennis elbow is more commonly known as now? Well, it's 1 to 3% prevalent rates in the UK, and it's 3 to 6 times more common than medial elbow tendinopathy or golfer's elbow. 5% of patients take sick leave, taking off a median of 29 days per annum, which has a huge socio-economic impact with all the days sick leave taken. It can last anywhere between 6 to 48 months in duration, and it's prone to recurrence, and approximately 1 in 20 patients undergo surgery. However, within our unit, that figure is much less than 1% of patients go on to have surgery. The risk factors for developing tennis elbow are manual workers performing repetitive tasks, smokers, either current or previous, an elevated body mass index. Werner looked at a longitudinal study over 5 to 10 years of patients who worked in a manual handling capacity, and noticed that patients with a BMI of 30 or more were more predisposed to developing not just cuff tendinopathy, but also lateral elbow tendinopathy. Medications can also predispose a patient to a tendinopathy. Statins with a median onset of 10 months. The fluoroquinolone group of antibiotics can also predispose patients to developing a reactive tendinopathy or even tendon ruptures from 8 days after they've taken the antibiotic course to 6 months after they've ceased taking it. Also genetics, the COL5A1 gene is found to be more prevalent in patients with tendinopathy in general. So, as the saying goes, we should all pick our parents more carefully, as we want to try and avoid inheriting these genes wherever possible. So what are the clinical signs and symptoms of a tennis elbow or lateral elbow tendinopathy? Well, it's localized lateral epicondyle pain, and the mode of onset is really important. Was it a sudden onset, i.e. the patient remembers performing a backhand during a game of tennis and they felt something go, or did it come on the next day after a prolonged period of gardening, decorating, etc., i.e. new unaccustomed activity, a period of overuse? Beware of the patients who can remember one single episode or one single backhand or causing sudden onset of pain, as this may indicate a full thickness tear of the common extensor origin. We have a cohort of patients who remembered catching objects, the backhand, hitting the ground with a golf club inadvertently, and they had full thickness tears that didn't respond to physiotherapy and needed a common extensor origin repair, which is very different in its management to somebody who presents with an insidious onset just due to overload. The aggravating activity is gripping, and it's usually gripping with the elbow extended, as when you grip, you load the common extensor origin, and when you extend the elbow, it also compresses the tendon as well. So it becomes increasingly painful as you grip and move the elbow into extension. It can be tender to palpation. Resisted tests can be painful, as can stretch tests. So clinical examination for lateral elbow tendinopathy, you can use the Cosen's and Maudsley's tests, which are resisted middle finger or wrist extension tests, which are commonly seen in clinical practice. However, the clinical utility of these tests can be questioned, as there's very little data on sensitivity and specificity for those two tests alone. The more reliable one is the one described in Zweras's paper, where they look at a grip strength test. Now, you look at grip strength in elbow flexion at 90 degrees and compare it with pain-free grip strength in the elbow extended. A 5 to 10% decrease in pain-free grip strength in elbow extension compared to grip strength in flexion indicates a high sensitivity of over 80% and specificity for common extensor origin tendinopathy. So they're more painful when they grip in extension, therefore they can develop less force, and so they have decreased grip strength. And that's because you compress the tendon as well as load it when you grip in that extended position. So you do need a handheld dynamometer to look at that one. So what about tennis elbow? What's going on in terms of pathophysiology? Well, we know we have a local tendon pathology with a decreased ability to tolerate load, but we also have increased expression of glutamatergic pathways. So, and we have high levels of glutamate, which is an excitatory amino acid in the common extensor origin on biopsy. So glutamate has a really important function, as it's a sensitizer. It lowers the firing threshold of peripheral nociceptors, and therefore non-noxious stimuli can therefore cause nociceptors to fire, causing peripheral sensitization. We also have the burning question, well, what's the changes going on within that common extensor origin locally? Well, people used to discuss, was it inflammatory versus degeneration? I think that the jury's definitely sort of coming to a version where it's inflammatory and degenerative changes coexisting in the same tendon specimen, because we have the presence of inflammatory cells such as macrophages and lymphocytes in chronic tennis elbow, with inflammatory mediators such as cytokines, substance P, MMPs, all existing alongside degenerative cells. So it's a coexisting pathology. We also have pain system changes in that common extensor origin tendinopathy, and that's probably due to this glutamate, etc., that we mentioned before. So you get a widespread reduced threshold to temperature and mechanical pressure. So impulses such as temperature and pressure that would normally have been non-noxious the nociceptors become sensitized by the glutamate, etc., and now become painful. So we get pain on what would have been normally non-noxious stimulation. Both pressure and thermal, as we've said. Now, this thermal hyperalgesia or hypersensitivity can be relieved by guanethidine. Guanethidine is an autonomic nervous system blocker. So we think if a patient presents with thermal hypersensitivity, there's an element of autonomic nervous system involvement. If they have pressure sensitivity, we can look at a pinprick test when we're examining somebody later to see when they have any evidence of temporal summation. Now, both these thermal and pressure hyperalgesias have been commonly seen and are evidence of central sensitization within the nervous system. When this Plansanger looked at evidence of nervous system sensitization in painful tendinopathies throughout the whole of the human body, the ones that were found to be most commonly seen were in those with patients with tennis elbow. So it's been extensively investigated and found to be present. So temporal summation, this is where successive impulses on afferent neurons combine additively in a postsynaptic neuron to produce a graded potential that may cause the neuron to transmit a nerve impulse or action potential that couldn't be caused by a single afferent impulse. So what we're saying is repeated impulses in the presynaptic neuron add up and summate and cause firing in the postsynaptic neuron. And you think, well, why is that important? Well, that could mean repeated mechanical stimulation, such as when you're performing your mobilizations, may initially be non-noxious, but they may add up in terms of action potential wise and cause firing in a nociceptor at the postsynaptic neuron. So something that initially might be non-painful may, over a period of repetitive impulses, cause pain. So in a patient who has evidence of temporal summation, you may well want to avoid hands-on treatment. We also get motor impairments in extensor tendinopathy. So we get bilateral deficits, even with unilateral symptoms. You get changes in a wrist gripping posture. So patients tend to grip in more of a flex position, about 11 to 12 degrees, in comparison to patients who are pain-free. There's a deficit in speed of motion and reaction time in both upper limbs. And we also see from the Liverpool paper, global upper limb weakness in the shoulders, elbow, forearms of a patient with tennis elbow, and also in chronic cases, motor cortex reorganization. So this is the wrist angle. This is from Bissett's study that shows there's a deficit of approximately 11 degrees in terms of wrist extension, comparing patients with tennis elbow with patients who are pain-free. And therefore, one of the first things I teach my patients to do is to find the wrist neutral position. So you can find that by placing your forearm along a table, making a wrist grip, and that's your wrist neutral position. And they need to maintain that whilst performing upper limb activities, making sure that they don't lose that extended position. To go into flexion as you try and grip means you're mechanically disadvantaged. And as we said, the Liverpool paper that we talked about before showed gross weakness in most of the major muscle groups in an affected upper limb. And therefore, rehab shouldn't be just directed towards the elbow, but we should look at global strengthening programs as well. What about psychological factors? Well, kinesiophobia, distress, and catastrophization has been linked with tennis elbow as well, which should also be addressed during treatment. And one of the things that we can do is, if you look at this paper from David Ring, despite the best efforts, medical treatment doesn't alter the natural history of this condition. So Ring has said that orthopedic surgeons can benefit from learning effective communication strategies to help convey accurate information that is hopeful and enabling. So first of all, we need to tell patients that 90% of patients, even if they're have a wait and see approach. After a year, 90% will be cured or most definitely improved. And therefore, we need to give patients hope and tell them that they will get better. And if they need it, physio can actually enhance that return or increase the chances of getting significantly better or becoming pain-free. So we need to change patients' expectations of physio, because people with positive expectations of physio with tennis elbow get better. Those that don't. And patients often choose surgery due to low expectations of physio, not due to their structural or symptomatic responses. So it's more important what we say to the patient more often than what we actually physically do. So therefore, physio needs to be promoted positively and optimistically by referring GPs and surgeons. So the message delivered by the surgeon often influences the expectations of physio. So I ask the surgeons I work with to set the scene for physio. The first scene is, I'm going to refer you for physio and I'm going to see you again in 3 months. If you know better, we can talk about injections or surgery. That's already told the patient that they don't expect them to get better, and it's already alluded to the fact that there are better treatments out there that may help them, which we know isn't true in terms of efficacy. Steroid injections actually make you worse than if you do nothing at all, and surgery is no better than wait and see approaches. However, the second approach is, I'm going to refer you to our team of specialist physios and review you again in 3 months to see just how much improvement you've made, puts a positive spin on the referral to physio, and already puts the patient in the right mind frame as to that the physio is going to work for them. And often expectations drive success. So what works? Well, physiotherapy is one of the most common treatment options, with over a quarter of all patients with tennis elbow referred to physio, with a large amount of evidence to support exercise in chronic tennis elbow, and it's also found to be cost effective. So how can exercise affect all those the dressing elements we talked about before, which is changing localized tendon pathology, altering pain sensitization, altering motor impairments, and addressing psychosocial issues as well? Well, local loading can cause viscoelastic properties of tendon to change due to changes in stiffness of the tendon, which is more changes in sort of material changes rather than cross-sectional areas. The exercise can also affect neuromotor control and affect the pain sensitization, but also we have graded exposure. So if a patient is fear avoidant, it actually is a graded exposure treatment to allow them to become accustomed to movement and become less fearful of it. And all the physios did was gave me exercise. We've heard it all before. Most patients expect something more than exercise therapy, and they give up because they've not been told about the correct parameters for exercise. They've not been told how long to do it for. And after 2 to 3 weeks of performing the exercises with no improvement, they give up. They don't realise that they haven't been told that they need to comply with the exercises or complete the exercise course, and it may take 3 to 4 months before they see a huge deal of difference. They're often not told how often to do them for, or what exercises, or they forget them, or they're bombarded with 5 or 6 different exercises, when in reality they should be given 1 to 2 exercises with very clear examples of how to progress or regress dependent on symptom reproduction, what load should be used, how many repetitions and how many sets. So patient education is absolutely vital in the management of tennis elbow. And also we need to individualize our treatments. There are no recipes for success. We need to look at an individual and prescribe exercises that are pertinent to them. So here in the top right hand side with his Manchester United shirt is Wayne, and then Shane and his twin brother who hasn't played football in his life and likes beers and lagers. So Wayne, we might think, has more of a reactive tendinopathy. He's a fit young man, so we might think about sort of reducing load on him. Whereas Shane probably has metabolic syndrome going on there, and we maybe need to look at systemic factors such as reducing weight, reducing cholesterol to make him systemically better, and also talk about loading his tendon because he's probably got degenerative changes in those tendons. So not all tendons are created equal. Metabolic factors can have a huge influence on outcome. And we're also going to look at quantitative sensory testing in patients to see when they have any evidence of this central sensitization around the elbow. So the management program we talk about is we're going to educate patients about time, responses. Myself, I let them bring on low to moderate discomfort that settles within half an hour of them having completed exercises. Then I will also tell them I don't want pain that makes them worse first thing in the morning, or including their morning stiffness that they often get in tendons after periods of inactivity, and it shouldn't make pain worse. And I'll often use the sunburn analogy. If you want to develop a tan when you're on your holiday abroad, if ever we can fly abroad again, then you would spend increasing times out in the sun, but you wouldn't go mad for the first couple of days wearing no sunscreen and no clothes, because you'd end up with a raging sunburn that took weeks to settle. Same happens with a tendon. You load it gradually over a prolonged period of time to get healthy loading within the tendon. We don't want to overload it, which would be the same as developing a sunburn after a few days. And the load is individualized to a patient's current capacity, and it's very slow progression. No more than 10% increase a week in terms of load or repetitions. So the clinical assessment I tend to use is looking at pain-free grip strength. Pain-free grip strength has been shown to be the most reliable, sensitive indicator to change over time in patients with tennis elbow. So I use a handheld dynamometer. I use a standard testing position of 90 degrees elbow flexion, mid forearm pro and supination, so it's reproducible. And I will look at that grip. And then I've also got data around that shows patients what their grip strength should be in terms of age and sex stratification. So I can also show patients if they're not as strong as their counterparts in the population who are the same age and sex as them. I'll also look at global upper limb strength. I'll also use the patient-rated tennis elbow evaluation, which is known as the PRTEE, which is a patient completed outcome measure specifically designed for patients with lateral elbow tendinopathy. I'll look at their risk factors such as fluoroquinolone use, steroid use. I'll ask them about their beliefs and attitudes, and then I'll perform tests looking for central sensitization. Now, the patient-rated tennis elbow evaluation is validated in both English, Spanish, French, Dutch, and Italian, and is easily found on the internet and downloaded. It's self-administered, and it rates pain and disability equally, with 15 questions ranging with a score from 0 to 100. So these are some of the questions. Rate your pain when you're at rest with repeated arm movements, etc. And you'd add them up. Specific activities for the disability, rate the amount of difficulty you have performing, sort of turning a doorknob or a key, pulling up your pants, opening a jar, wringing out a washcloth or a wet towel. And again, you'd add them up when they've scored all their questions, and it gives you a score out of 100. And as we'll discuss in a minute, that might help us stratify patients into who is high, moderate, or low risk of developing long-term problems with tennis elbow. The central sensitization aspects, I'll then look at quantitative sensory testing, looking at thermal detection, mechanical hyperalgesia, which is that hypersensitivity to a mechanical load, and temporal summation. So thermal detection, I'll look at holding an ice cube over the lateral epicondyle or the elbow and holding it for 10 seconds. If the patient complains of a visual analog scale sort of pain of more than 5 out of 10 when holding an ice cube there for 10 seconds, that's supposed to be pretty much hugely sensitive for thermal hyperalgesia or hypersensitivity to temperature. So that will make me think they have thermal hyperalgesia, which we know it correlates with poorer outcome. I can also look at hypersensitivity to mechanical pressure by using one of the pressure transducers pictured in the bottom right photograph there, where we look at how much force we have to press through a bony point before it increases pain over the area. And I'd compare the right with the left. And then I'd also use a weighted stick to look at temporal summation. And we'll look at how we do this in a minute. So the 10-second ice cube hole came from Prue Tilley and Leanne Bissett's paper, and looking at the reliability and validity of using ice to measure cold pressure thresholds. And as we said, holding that ice cube there, causing for 10 seconds, causing pain on a visual analog scale of 5 or more is indicative of thermal hyperalgesia. So you don't need any fancy equipment to test for that. Temporal summation is using a weighted stick. So I'll use a weighted stick over the lateral epicondyle. I'll put a 1 centimetre square in there, and I will perform a single weighted stick drop. I will then ask the patient to give me a pain score for just that single strike. I will then repeat it again. I will do 10 successive drops of the weighted stick at 1 second intervals. I will then ask the patient after 10 successive strikes what their visual analog scale is now. If the pain after repeated strikes is higher than following the single strike, that's evidence that they have temporal summation and may not respond well to mechanical pressure, such as MWMs or taping or strapping around the elbow because of that repeated mechanical input. So Coombs has talked about in 2015 that use the patient-rated tennis elbow evaluation that we talked about before to stratify patients in terms of low risk, where they have a score below 33, and we can give them a wait and see approach and give them general advice about wrist posture, advise to flex when they're lifting anything in terms of elbows to avoid compressing and loading the tendon at the same time. If they have a score of more between 33 and 54, plus or minus significant risk factors such as manual work, low job satisfaction, refer them to physiotherapy and reassess them at 2 to 3 months. Remember, we're going to tell these patients a minimum of 3 months before they see a marked improvement. However, if they've got a score of 55 plus or evidence of central sensitization, so that ice cube test or increased pressure sensitivity or the temporal summation, or they've got coexisting neck or shoulder pain, then it may be physio plus pharmacological therapy from the GP and reassess again within 2 to 3 months. So remain vigilant. For patients with the high levels or high scores of above 54 on the PRTE, and remain vigilant to patients who have a presence of thermal hyperalgesia or pressure hyperalgesia or temporal summation. And with these patients, I will often perform pain-free exercise at onset rather than going into pain. However, if they've none of these, I will start thinking about exercise, loading program, whether it's concentric, eccentric or isometric, with no pain at all. But with patients with elements of central sensitization, I don't want to stir up their problems, and I'll load them with pain-free levels. But that's a different presentation about how we'd load people and how we'd progress. So I hope you've enjoyed today's presentation, just really saying how you can assess patients a little differently. So in conclusion, remain vigilant with patients who present with signs of central sensitization. Be aware of systemic factors that can influence outcomes. So is the patient diabetic? Do they have other systemic problems going on, such as rheumatoid arthritis? Have they a high body mass index, which is going to affect their long-term outcomes? And use that patient-rated tennis elbow evaluation, that self-administered questionnaire to help triage patients. I hope you've enjoyed the presentation today. If any of you want to get in touch in future, my Twitter address is there, Val Jones 2305, and keep loving that elbow.